And we're going to kick it off with Matthew Lamb from West Park Healthcare.
Thanks, Catherine. Okay, so, oh good, it does work. So as Catherine said, my name is Matthew. I'm an occupational therapist, and just to pull it back to a bit of what Dr. Frey said, I do the presentations that are part of the back care and patient handling program at West Park. So I'm one of those experts that says I'm an expert. No, I'm kidding. So basically what I'm going to talk about today is just the back care and patient handling program at West Park Healthcare Center. It's really nice to have Dr. Frey talk a bit about what he did early on, because it really validates a lot of the stuff that we do and really gives us support into how we generated our program. Okay, so mine's not changing, so I'm just going to go over here. So we're going to start just talking a bit about the organization itself, moving on to the actual program that we have at West Park, talking a bit about data collection, just very preliminary things. Obviously, this is there's a lot of people here from research. They're going to look at what we did and really say, well, that's not great evidence, and it's not. Mainly because all we're doing is we're trying to work really on the ground with our nurses, with our healthcare staff, and slowly, little by little, as we develop our program, and as we have been developing our program, we will end up implementing a lot of outcome data. We wanted to make sure that our program was up off the ground first so that we could really provide the best program for our nurses and for our care staff. And then the last thing we'll do is just talk about future steps. So, West Park Healthcare Center is, I really wish I had my slides.
Matthew, can you just hold that up a little closer?
Sure. You know what, I'm probably just going to talk from here. It's a lot easier now. So, West Park is a comprehensive inpatient and outpatient facility. We operate just under 500 beds from various services. There's clinical inpatients, there's outpatients. We also have maintenance, environmental services, food services, basically everything that a regular hospital has. Now, the part that we focused on for our back care program to date has been our direct service provision staff, so nurses, client care assistants, and that supporting medical staff. The difficulty with our facility is that each independent unit has an independent patient population that is completely different from the other patient populations in the hospital. So we have a chronic assisted ventilatory care unit, we have an amputee unit, we have neurological impairments, and MSK, and functional enhancement, which is what most people would call slow stream rehab. In terms of patient care for nurses and client care assistants, those populations have basically little to nothing in common. So our challenge was to make sure that we developed a program that would support all nurses for all departments and all units, irrespective of where they are. Personally, I am an occupational therapist from the outpatient department, which we call West Park Rehab Plus. It's a combination fee-for-service and globally funded department that takes outpatient services, that delivers outpatient services to patients in our community, inpatients that have been discharged and still require outpatient services, as well as any third-party insurers, funders, and those people. So again, I kind of like to reiterate what Tillich said about Susan's comments regarding the integration of for-profit or the existence of for-profit facilities. They're here, they exist, and they should be accounted for better or for worse. So our facility, my department consists of multidisciplinary teams of approximately 20 therapists and support staff. And again, we do provide that fee-for-service healthcare. Hopefully I don't take too many questions about that particular side, but they do exist and I do have some answers. And if not, I think my manager is floating around here to save me when my butt gets on the fire. So, part of what I do as an outpatient occupational therapist is actually liaise with the occupational health and safety department of my own hospital. And that's how I'm standing up here in front of you, because my part of the back care and handling program at West Park is to provide that education and training for the nurses at our hospital. So I saw a really interesting report that nursing is actually the highest risk occupations for MSDs in North America. And when I tell that to the nurses during my presentation, ironically, they all talk about, well, mining, construction, no, and no, it's not. So really, again, referring back to Dr. Frey, how do we best care for these caregivers? And I think the answer that we've sort of been dancing around that is the approach we take at West Park is comprehensive care, not just training, not just equipment, not just policy and procedure, but a combination of everything that we can within the purview of our facility to help these caregivers care for not just the patients, but also themselves. I don't even remember how many times I've asked nurses, so who, in an ideal situation, whose safety should be number one? I'd like to put that to the crowd. Whose safety is number one? Ours? As caregivers? Does anybody here, has anybody heard the answer patients? Does anybody believe the answer is patients? Does anybody believe that the answer is ours? Raise your hand. I challenge the nurses to say, why can't it be both? Why can't you think about the patients and think about yourselves? Because that's really how everyone stays safe. That's the ideal situation. That's when nothing happens. If the patient is going to fall, yes, then you want to look after yourselves. But if it's not an emergency situation, ideally you really want both of you to come out of this not looking too bad. Anyway, that's a little aside. So the components of comprehensive safety at West Park are obviously those 5 pieces: policy and procedure, best practice manuals, education, equipment, and follow-up. And this program is by no means done. We require continuous improvement. We require collaboration between upper management, staff, vendors, different departments. And really, what we found to be quite successful is the appointment of champions for specific projects. Because one person does not know everything about everything, much less when it comes to health and safety, much less when it comes to even back care. So what we've done at West Park and what we think is quite innovative is having people choose to take up that mantle of making sure a specific part of our healthcare program or our health and safety program is the best that it can be, and not relying on one person to develop the whole program by him or herself. So the policy. I'm just going to really quickly go through all the different components of our program. So the policy, individualized step-by-step patient handling processes from intake to discharge. We actually do have a patient mobility assessment, but in our policy and procedure, we also have a pre-mobility assessment. And that kind of sounds a little odd, but basically what it is the nurse, when they have to do a lift or a transfer, the second they walk into that room, they have to look and see what that patient is like, what that environment is like. And I've been encouraging the nurses to think about what they feel like. Have they been playing with their grandkids all Sunday night and Monday morning they feel a little bit stiff and sore? That'll affect how they do a lift and transfer. And I want our nurses to consider that before they do something that they might consider risky, because it's important. Again, I can refer back to Dr. Frey, basically all presentation, but compliance versus competence is a huge part of what we do. It's great that they follow the line and toe the rules when things get troublesome, but day to day, what do they do? MSDs don't always show up during a fall or during an emergency incident. They show up by doing the exact same thing thousands and thousands and thousands and thousands of times. An example of that is when I talk to my nurses, one of the first things that I say is, well, how many times do you do a sit to stand each shift? Answers vary based on unit, but let's say 5. So 5 a shift, not too much. How many is that a week? That's 25. Still, not too much. How many is that a month? Approximately 100. That's high. How many is that a year? 1,200. How long have some nurses been in the field? 10 years? All right, you've done that one small part of your job 12,000 times. And that's not the heaviest part, that's just helping someone go from sit to stand. That's not even the majority of your job. So it's not those emergency situations that we concentrate on at West Park, because those are the ones that you sort of think about, logically work your way through and try and do your best, because there's a time frame. It's those everyday activities that you do over and over and over again that lead to those injuries that have difficulty being accounted for, and those are the ones that frankly cause the most trouble with the WSIB. So again, for policy, we talk about multiple patient handling scenarios because we have multiple units that have to deal with multiple populations. Multiple anthropometric scenarios because, again, being 5'4" and 110 pounds, trying to turn someone who's 6'4", 310 pounds, is different when those situations are reversed. The policy also includes direction to other documentation and also additional resources, and I'll go into those later on in the presentation. Actually, I'm going to go into it right now. Best practice manual. So at West Park, we have a written document, and it's also available electronically, that compiles the current best practice techniques from multiple sources, research articles, other best practice manuals, presentations. Standards, codes, and various sources that we have available to us from researchers and from people that are sitting here in this room. We've updated and amended our best practice manual as of this year. And it's not just the Occ Health and Safety Department. We bring in, like I said, we bring in champions. We have nurses, OTs, PTs from all various units coming together to talk about how they do what they do best and how they have to do it based on their various limitations, not just physical, but also time constraints and people constraints. And I know in in hospital, time constraints and space issues and all those things pale in comparison to that of home care, but they still do exist, and they still need to be addressed. Otherwise, our policies and our program would be incomplete. Our education. I can probably speak to this better than all the other sides, but basically, our education is designed to be targeted to a nurse and to be relevant to that specific nurse because of that difference we have in our departments. It starts with the orientation to all new employees. That orientation session has 2 parts that are related to MSDs. One is an MSD presentation that's done to all employees, whether they're clinical or non-clinical. And the second is a back care and lifting presentation to all clinical employees. The second thing that we do is a back care presentation on each individual unit, having no more than about 15 nurses per presentation. That I can understand to be a huge funding issue because not only do you have to cover the nurses, you have to pay the guy that presents it to 15 nurses, and Lord knows how many nurses exist in your facility. But that's something that our facility has decided to do because it's found that those presentations have been relevant and they capture more of the day-to-day issues that aren't covered by the orientation presentation or could have been forgotten by a nurse that's worked in our facility 10, 15, 20 years. Finally, we have a back care video. And it's really funny how a lot of the research has maligned basically everything that I've been talking about. But it's important to know because all those studies have their limitations, and and the studies that do sometimes look at those in isolation of everything else. And that's why we don't do any of these things in isolation of everything else. We try to make this a comprehensive whole. So that back here video is a learning-based education module. It's in progress. It's continually available to all staff. It's produced in-house. It's actually being produced in-house. And it's tailored so that not every nurse has to look at every single part of the module. If I'm on, let's say, a amputee unit that doesn't really use a ceiling lift very often to get their patients in and out of bed, you don't have to watch the ceiling lift video because it's not applicable to what you do. If you do shifts on another unit, such as chronic assisted ventilatory care or complex continuing care, you might want to look at the video, and it's there if you do. But we're targeting to the nurses that are on the units doing their jobs and making sure that they get the information they need. Certainly no less, but as a lot of educational research has pointed, certainly no more. Because information that you don't need makes you lose information that you could use. Our equipment, safe, simple, and population specific. So our amputee units, we make sure we have abundant of wheelchairs, transfer boards, and anything that the nurses have deemed to be useful and the physios have deemed to be useful. CAVC, there's a ceiling lift on above every single bed. And there's actually an innovative track system that we implemented on our unit to make sure that it's not just accessible along that single thin strip of track, but actually accessible within a two-dimensional range, not just one. And I'll show you guys that a bit later. Functional enhancement, these people are slow stream rehab, they need to get better, but they're not strong. So we have these things called no-lifts, which are basically standing transfers that nurses don't have to be used as SASCA poles by their patients. I love that term because the human body is basically one of the worst designed SASCA poles I've ever seen. So when you have a nurse standing beside a patient saying, "I'd like to help you stand," the first thing a patient usually does is try and grab you and drag you down to the ground. Mechanically, I'm sure Tilly can speak to this later on, that is the worst thing you can do to your body. And if your body fails, you're ending up on top of the patient, or you're both ending up on the floor. So part of that education is to say, if somebody reaches for you, it's not an emergency, and you know that they're going to try and use you to pull themselves up, that's not somewhere you want to be. Oh. The last point that I want to speak about here is the equipment is actually serviced by independent staff at the facility. It's not, something looks broken, we have to call in the vendor, make sure it's fixed, and then bring it back. We actually have employees that specifically service specific pieces of equipment. We have a ceiling lift guy. We have a wheelchair guy. We have 2 minutes left. Uh-oh. Okay. This is what I wanted to show you. It's called an H-track, and this is something that I don't know if other facilities have, but I thought it was really cool, so I took a photo of it. Basically, this spans 2 patient beds, and I know 2 patient beds means that you have 1 ceiling lift per 2 patient beds, but that's the price we pay. And basically, the track is sitting on a track. So instead of having to follow the one line of the one track, you can follow the one line of the one track and then move the second track so that you can access not just a line or even a curved line, but a full 2-dimensional space, a square of that patient room. So no more pushing and pulling the patient to make sure that they get, over top a wheelchair that can't be put any closer because of other furniture or other pieces of equipment or other patients or family that are hovering around. And I thought that was actually a pretty cool thing. I don't know if you guys have that in your acute care or your long-term care facilities, but it's something that I think that we found really, really useful on our units. Continuous follow-up, huge part of a program. Unit-specific presentations are done annually so that, again, it's not, Dr. Frey, it's not the exact same thing over and over and over again. What we try to do is make sure that something new is brought in, and it's based on a problem-solving approach of what do nurses want to hear about? What issues do they have? Because not only is that different from department to department, from unit to unit, that's actually different from group of nurses to group of nurses. So really, if they want to learn something, it's our job to teach them that. It's not our job to tell them things that they've already heard or they don't really want to know or they cannot apply the second they leave that training room. And I think that's a huge part of the success, is the specific education process tailored to an individual, a group, a unit, and a facility at all possible times. Numbers, because everyone loves numbers. These are our incidences of back care injury by year, and we started implementing this program continuously over time. The 2013 to 2014 drop, obviously we can't find causation, but that's when we started our annual back care presentations. We don't know what the data looks like now, but we want to find out. So for any of you researchers who are super interested, West Park is located at 82 Buttonwood Avenue, M6M2J5. RSI injuries by year. Again, the slope is down, but is it super down? We don't know. We don't have the statistical probability, and up until very recently, we kind of didn't have the resources to find out. So what we want to do is find out. We want to put our program to the rigor and to see if it can hold up to what you wonderful people in research can throw at it. Because we think it's good. We have the feedback from our presentations for our on-ground, on-site staff to say it's good, but we want to know. And the only way we can know is by finding out through research. Future steps that we have. Like I said, that back care video module is coming up online. It isn't finished yet, but hopefully it will be soon. Again, implementing that continuous monitoring of injury data, and then finally, optimization of the program. If research finds that a piece of our program isn't as efficient as it could be, we want to know and we want to improve. So again, it can't be just training, it can't be just equipment, it can't be just one thing. Where we have found success, if we indeed truly have found success, is trying to make sure we cover every single base as best as we can. And we do that by working as a team and communicating well as a team. Not just within a department, not just within a unit, but within a facility as a whole. So I think that would be my take-home point for this one. Thank you.